shift, don't I? So basically, I've come here today to talk about the work that we've been doing for pretty much the last 4 years in the North East and North Cumbria. I am an intelligence analyst by trade, but I just get passed from pillar to post and get asked to do all kinds of things. So my latest project has been on developing the Healthier and Fairer programme within the ICB. So just an introduction of what the Healthier and Fairer programme is. So it is a whole system, a whole health and care system transformational programme of prevention, healthcare inequalities, and social and economic inequality projects. Now, when I say social and economic inequality projects, it's about the NHS's contribution to those social factors rather than the NHS curing poverty. A little bit of dryness here in terms of the governance structure, just to set the scene. So the advisory group, the Healthier and Fairer programme, feeds straight up into our exec committee. So the decisions and the information that we feed up does eventually get heard. But more importantly, it's made up of those three categories. We've got prevention, healthcare inequalities, and then the NHS's contribution to the broader determinants of health, which is a nice, easy thing to say last thing on a Tuesday. And under those, there's individual work streams, which I support each of them in different ways. And I'm going to go through the main criteria that I've had to apply to this programme, because as you can see, it's quite a hefty programme to do a lot of detailed work on. So one of the first points is we deliver intelligence and insight, as everybody does who works as an analyst in any field. But specifically for this, we needed to identify and understand the needs of the population within the North East and North Cumbria. So context is we've got about 3.1 million people living in our region, so it's quite a big area, and 33% of those are residing within the most deprived deciles. We provide evidence-based advice on emerging themes. So what I mean by that is it's basically for looking across what's coming out of existing evidence, making sure that's cited within all those different work streams, and then telling them how it might be pertinent to work that they're thinking about doing or that they are doing. Healthcare needs assessments, and these are done in various stages. We either do really robust healthcare needs assessment in partnership with OHID, local authority analysts, other actually academics as well. So we have a lot of input into our needs assessment. And for each of those work programmes I showed on the organogram, we've established what the needs of the population are under each of those categories. And then delivering training, nothing like that previous presentation. I must admit, I'll be taking that back and trying to embed that into the training scheme. But identifying, not just for analysts, but actually commissioners on the ground, how to look at the data through a different lens, not just the outcome being delivering universal healthcare, looking at proportionate universalism and diverting some of the funding, which is always a bit of an issue to bring up, to the population or the cohorts within the population that need it most. And then obviously measurement and demonstrating impact, which we always have to do. And then routine reporting, which is not very good, is it? We don't like routine reporting. So this is an example of one of the population health profiles that one of my colleagues developed. She is very artistic and amazing, and I'm so lucky to have access to brilliant analysts to do this. But this was basically, we talk a lot about the prevalence of long-term conditions, and we talk about healthcare inequalities. But what we needed was just one simple slide that we could put in front of executive members or other clinicians, just so they could see the scale of the problem and the differences in the demographic makeup of people who live within the most deprived communities within the North East and North Cumbria. And I don't know if everybody is aware, generally we don't have a very diverse population. I think it's about 93% white British. So there's often a risk that those not within those white British population are overlooked because they're not seen as, in terms of volume, as a lot. But actually, when we look at ethnicity through an inequalities lens, 12% of the population within IMD 1 and 2 are actually non-white British, which is almost a double disadvantage when you're thinking about those inequalities that communities face. Oh, are we clicking on? No, it wants to stay on this. Right. So obviously I can't analyse everything all the time. So following the needs assessments, what we decided was the pertinent things that came out of that, we would develop into dashboards that would be routinely updated, so we weren't having to do needs assessments every 12 months. And those dashboards have been made openly available to local authority colleagues, people working in public health, people working within the acute and mental health trusts. So we're all working off the same data. We've done estimated modelling, particularly around increased weight, because when I was looking at, we all know it's a huge issue within the country generally, but there wasn't a lot of evidence out there in terms of being able to identify need. And when looking at routine data sets like primary care, BMI, height and weight aren't routinely collected, it's opportunistic. So we didn't feel that was representative of necessarily what we needed to do. So we produced a crude model, it's still yet to be ratified, but it gave us an understanding of what the estimated need was within our population. And we were then able to put that in front of the people who hold the purse strings and say, actually, we don't have tier 3 services to treat. We're not really doing a lot of the preventative work around obesity. Look at the scale of the problem, and we deliberately didn't put it in terms of percentages or rates. We wanted to avoid that percentage blindness where people think, oh, that's just another percentage. We actually gave them the figure, which was roughly about 750,000 people in our region. And again, produce those Power BI dashboards. So just again, some examples. In the right-hand side of the slide, we've got an example of the alcohol prevention dashboard that we developed. The top part's just showing you the different categories that are within that dashboard, and then I have included an example of how we've segmented the data based on primary care data to try and encourage primary care practitioners, or GPs, nurses, about alcohol identification and the delivery of brief advice and information. And we actually did a very specific pilot on that, on how can we identify or how can we increase the visibility of alcohol as an issue when people are going into primary care with other conditions and there's limited time. And we did a very specific project of highlighting if you address alcohol as part of a routine checkup, say not hypertension and diabetes, because that's included in their health checks, but there was anxiety and depression. We included cohorts of individuals. They flagged it on their system. We did a very detailed project on that. So yeah, if you look at the middle graph on the right, you'll see that the age distribution of people asked about alcohol, it's mostly the elderly. And again, that's because it's picked up in their annual health checks when they have long-term conditions. Performance. So what we've done is we've embedded a culture of inequalities in our performance framework rather than just looking at month-on-month activity figures or your traditional figures. We've started to include inequality gap metrics as the measure that goes up to board, and we're trying to inform them, I don't want to say educate them, but advise them on what that means. We're also having to work with the analysts who do the detail behind those performance measures of not just using monthly data, using a cumulative position, because you're not going to it's not going to show you anything if you just use monthly data unless you've got huge data sets. And just trying to ease other people who don't work on this agenda day in, day out, the benefits of doing so. We produce narrative in very simple terms. So one of our work streams is health literacy. And because of that, I've adopted an approach of writing all of my reports in a very health literate way. I often, if I've got something going out, say to a commission and support unit, I'll go to one of our health literacy officers and ask them to assess the reading age of it, not because it's particularly complicated, but I want it to be understood by everybody and not just people like me who live and breathe it. So, example of the performance. So there's 4 categories. We're delivering on the core 20+5. We picked up the legal statement, and actually we worked collaboratively as a region. So it wasn't just the North East and North Cumbria. NHS England and the other ICBs within Yorkshire, we all worked together to think about the data sources and how that was going to be measured. Other elements, research and evidence is embedded in all we do. So all of the pilots, the project, any new commissioning intentions, we embed a baseline at the beginning. We work with our academic colleagues across the whole of the North East and North Cumbria, work with Newcastle University, Northumbria, Sunderland, and I've had the privilege of working with some pretty amazing academics over the years. We also have to build that culture broader than just this programme, because there's a risk that healthier and fairer or health inequalities is seen as their business. So we're starting to kind of embed that into other programmes of work, like urgent and emergency care, the mental health and transformation team, and just we're getting there slowly but surely. And data flows was the other one. We're having a nightmare with data flows at the moment, mostly because ethnicity coding, there's a lot of unknown or not stated. I was part of, slightly separate to this, but it's still inequalities, the Women's Health Programme, and we identified that a lot of women with cardiac problems were being diagnosed as signs and symptoms rather than an actual cardiac diagnosis. So that's an area that we're potentially going to investigate as well. So there's lots of work to be done.
Thanks so much, Anna. That was a fantastic summary and really interested to hear about your work. I've got a couple of questions here come through on Slido, so I'll just go through those and then we'll see if there's any more in the room. So the first question, it would be great to hear more about how you prioritise new developments when there's so much ground to cover.
Yeah, actually, that's something that we're having to really focus on at the moment. We're just about to start a prioritisation exercise, and it's an evidence-based prioritisation exercise undertaken originally by Public Health England. So we're taking their methodology and we're going to try and apply that to the whole healthcare inequalities agenda, aligned to that governance structure that I showed before. So we're just starting to collect all the evidence base, which we all have at hand, but it's just about combining that, then feeding it into that template and see what the figures come out with in the end. So that's the next stage for us.
Brilliant, thank you. And then let me just, with ICBs now so large, this is a word I can never say, with ICBs now so large, a lot of heterogeneity can be washed out. Do you develop your insights for smaller place-based footprints?
Yes, we do. So my role at the moment is to mostly deliver at that ICB level, but I also work quite closely with primary care networks. So I'm about to start a pilot on the identification of risks for high-risk drinkers rather than increased-risk drinkers, working with that primary care network and the community alcohol service to enable referral in for urgent FibroScan, and then also linking up with the acute trust to enable access to the hepatology department. So we do really small-scale projects, but we also then develop the insights for ICB level local delivery teams, which are really our local authority and NHS commissioning areas combined. So it's a range of geographies, really.
Brilliant, thank you. And there's just one more question on here. How do you select the metrics you report? Are they tied to particular interventions and their theory of change?
I have the benefit of working with a broad range of professionals. So each of the work streams have a Director of Public Health aligned to them. They have a strategic lead and they have a clinical lead. So when we are doing, say, needs assessment and we identify particular issues, that isn't then chosen as the metric. It is then taken to a wider steering group. There is public involvement often, not always, it could be better. But yeah, it's sort of co-production, working with the three disciplines, so the public health leads, the clinical leads, and the strategic commissioning leads. So it's a multidisciplinary approach to identifying those metrics. But ultimately, the sign-off for those metrics sit with the ICB directors.
Great, thank you. I think, so that's all the questions on Slido. Are there any questions in the room? Brilliant, Neil.
Yeah, hi. Just going to pick up, you mentioned it very briefly at the end, but it's the extent to which residents, patient, kind of public involvement is kind of part of the work, both in terms of the programme itself, but also in terms of prioritisation work, but also in terms of the kind of insight generation into why why a particular pattern is what it. I know you said it could be better. So whether you've got any thoughts on, you know, how it could be made better would be interesting as well.
Yeah, so each of those work streams, and I could have went into a lot more detail, but I was aware that I only had 10 minutes to chat. We have public engagement on the steering group. So in addition to those professionals I mentioned, we've got experts by experience sat on there, always feeding back their opinions or asking questions. And that actually helps me to tailor and to make the work more health literate, more appropriate, and it helps develop my insight into the topic and not just always go for that default position of what maybe the evidence is saying, because actually there's always a couple of other views to take into consideration. I'm working on a particular project at the moment, and this is a new thing for me. We're doing a burden of illness study, and we're at the point now where we've got all the data analysis done, and we're transforming that into a visual where I'm not going to be the one adding the narrative or the intelligence. We're sitting down with a workshop of experts by experience, and we're showing them trajectories, different pathways, or different examples of what the data is coming out with. And we're asking for their feedback. What do you think this is saying? And that will all be included in the end product when we finish that. But I think that's going to be at least another 4 to 5 months before that's in conclusion. But if that works, that's certainly something we can put forward as actually, when you're doing these projects, rather than an analyst providing the insight and intelligence. And I know commissioners always have co-production embedded, but I'm not aware that it's always part of our analytical processes. Does that make sense?